Good evening, everybody. Thanks again for joining us today on Orthopedic Specialists with our hip preservation webinar this evening. It gives me great pleasure to introduce today Mr. Tony Andrade and Mr. Tom Pollard, who are going to be talking to us today about hip joint preservation. Tony Andrade is very well known amongst hip arthroscopy surgeons. He's considered one of the early adopters of hip arthroscopy in the UK. And has been doing it at Reading since 2002. He's heavily involved with the hip arthroscopy societies, including ISHA and the NAHR. And together with his colleague, Mr. Tom Pollard, who in fact did his doctorate in early hip arthritis and lectures both nationally and internationally along the subject. We're really lucky to have them as part of the team. As you know, Orthopedic Specialists, we're part of a big group of surgeons that cover all subspecialties and within orthopedics, predominantly working out of the Harley Street Specialist Hospital. And we're going to hand over to the guys to take over. Thanks, Tony. Over to you.
Right, good evening, everybody. Let's get right. Good evening, and welcome to this webinar, and thank you to Orthopedic Specialists for putting this on for us. My remit really is to talk you through the. Oh, hang on, this is not the right. Hang on, just 1 second. Apologies for that. That's the wrong talk. I'm going to talk to you about groin pain, if I can find the right slide. It was there a minute ago. Let's try that. No, that's
great.
No, sorry, hang on. I think I'm going to have to. Shall I? Tom, are you ready to go with yours? And I need to try and find where this one's gone.
You're just on mute, Tom.
Okay, so thanks everyone for tuning in. As Rag said, Tony and I have worked in Reading for a number of years, specialist hip arthroscopy centre. What we'll do initially is just cover femoroacetabular impingement, which is probably the most important cause of groin pain in young adults. And then we can go back to Tony to cover the other causes of pain around the hip area. So I don't think that will cause any difficulties at all. So just by way of background, I've worked in Reading since 2012. I was previously working in Oxford rotation. I've got a subspecialist interest in hip and knee surgery, but particularly hip arthroscopy and young adult hip problems. And I perform about 200 cases per year. What we've seen over recent years is really an evolution in hip surgery in terms of our understanding of how the hip joint fails, how we can manage problems with the hip joint using arthroscopic techniques, and our understanding of the condition called femoroacetabular impingement as a cause of osteoarthritis. What we've realised is that essentially the 90% of cases of osteoarthritis of the hip that would come through to hip replacement, in which we didn't really know why they developed osteoarthritis in the first place, and you may recall early in your training being taught that, they do actually have an underlying cause, and that the vast majority of these are related to shape problems with the hip joint. And you can broadly divide these into femoroacetabular impingement, which is essentially too much bone, and acetabular dysplasia, which is a shallow hip socket and too little bone. And both conditions lead to cartilage damage, labral tears, hip pain and osteoarthritis, although these occur through different mechanisms. So we'll focus on femoroacetabular impingement, which is essentially a pathological abutment of the femoral head-neck junction where it impacts against the rim of the acetabulum. And this leads to cartilage damage and labral tears. Now, it's important to bear in mind that all joints will impinge at some point through the arc of motion. So if you think of the shoulder joint, then essentially your range of movement will get to a point where the humerus will impinge against the rim of the glenoid. And if you force it further, then either the neck of humerus will fracture or the shoulder will dislocate. And what we find is that patients with femoroacetabular impingement impinge earlier in that normal arc of movement. And the commonest situation this occurs is due to too much bone on the femoral side, which is called a cam deformity. So if we look at two hips here, on the left you've got a normal hip, and you can see how you've got a nice round femoral head with wasting of the neck, whereas a hip with a cam deformity here has a lump of bone on the edge of the femoral head-neck junction. Now, cams are actually quite common in the general population. So about 20% of men will have a cam deformity and about 5% of women. The causes are thought to be due to various potential problems, but there are theories related to subclinical childhood hip disease, such as slipped capital femoral epiphysis or Perthes, genetic influences, the way the evolutionary differences are in the hip shape between the sexes, so obviously to permit childbirth with females. And then probably the most important factor is the emerging evidence we're seeing about the impact of activity levels during childhood. Now, if we look at subclinical hip disease, so this is a patient on the top left there that had a slipped capital femoral epiphysis, and you can see how the head slipped backwards here, and they end up with this lump of bone at the front. And when they flex the hip, that can impinge. This patient here has no history of slipped capital femoral epiphysis, but they've ended up with a similar shape to their hip. These are three brothers. So top left, you've got a patient that we treated with a large cam deformity here. Bottom right, you can see that he's got his younger brother, the middle brother, has a large lump of bone anteriorly and did have some hip symptoms. And then in the middle there, you can see that his youngest brother, who's in fact asymptomatic at this stage, does have an abnormality on his X-ray at the femoral head and neck junction. Now, if you look at the natural world, what you actually see is that these hip shapes are replicated, and these are examples of gazelles. So this gazelle on the left is one that runs through on a plane in fast, straight directions. And the gazelle on the right is one that lives in woodland and is used to twisting and turning lots. And that has an impact on their hip shape. So the gazelle that runs fast in a straight line ends up with cam deformities, whereas the one that lives in the woodland has a much rounder shape to their femoral neck. So therefore, what we see with humans is that people that do a lot of sports from a young age, particularly football, running lots, they tend to end up with cam deformities. Now, what does that do? So the mechanism of injury here is that the cam deformity applies a shear force to the acetabular cartilage. So as it rotates round, the force comes into the hip socket here and rips off the articular cartilage, and that causes it to flap over and eventually lead to osteoarthritis. And the same cam deformity pushes a force on the labrum in the opposite direction. So you get a separation of the chondrolabral junction and a labral tear as the labrum is ripped off the hip socket. So this is an MRI scan. What we see in some patients on the left here is a pressure effect cyst at the femoral head-neck junction. If you segment out the femur and rotate it round, then you can see how that cyst directly impacts and collides with the rim of the hip socket. and that causes that stress to the labrum and to the acetabular cartilage. So on a with multiple collision episodes, just seeing if this video will actually run. It may not work. I've got the spinning wheel. Let's try that again. Yeah, here we go. So if you imagine, so you've got the patient with a cam deformity, they flex up, and particularly if they internally rotate, they're going to be impacting that cam deformity on the rim of the acetabulum. And over time, that's going to lead to failure. And it won't occur immediately, but depending on the severity of the cam and the frequency of those episodes, you will get damage. And obviously with certain sports, it's likely to be more frequent. So for example, with martial arts or potentially with horse riding, which involves abduction, internal rotation, they're particularly prone to getting damage in this mechanism. Now, there is a different type of impingement, which is called pincer impingement, and this relates to an acetabular-sided problem where essentially there's too much bone in the acetabulum. And this is either due to a deep socket or a socket that points backwards rather than forwards. Now, with pincer impingement, what you see is that you get a much narrower line of damage, and effectively the labrum gets crushed by the femoral head-neck junction. So over time, this repetitive damage will lead to it ossifying and also causing damage in a fairly narrow strip to the articular cartilage around the rim of the socket. Now, this slower process means that the patients tend to present at an older age. It tends to be slightly more common in females than males. So what we see when we look inside a hip, so you've got the femoral head here on the right, and the acetabular cartilage here on the left, and the labrum anteriorly. So initially, if you think about that shear force there, that's causing blistering of the articular cartilage. And that's what we call a wave sign. Here you've got the labral tear adjacent to that. You can see how unstable and inflamed that labrum is where it's being bruised. What you see next is separation of that chondrolabral junction. So you can see how the acetabular cartilage is now starting to peel off as that chondrolabral junction has failed. And then this gets worse, and those flaps will extend more towards the center of the acetabulum. So we're now looking at significant cartilage loss potentially, and then eventually that flap that's loosened will detach, and you end up with an area of bare bone. And this is in a 23-year-old female patient. And what you can notice here on this picture, it quite nicely demonstrates how the acetabulum is quite badly damaged in a focal manner, but the femoral head cartilage still looks perfect. And this is always the sequence that you see the damage occurring in. And what we suspect is that once this acetabular defect gets big enough, the femoral head can then fall into that defect, and that's when you start to get damage to the femoral head cartilage and inevitable osteoarthritis. So the patients that we see, there's a very wide range of presentation from very young, so teenagers, some as young as 13 years, up to 60. And I mean, in the older age group, you do need to be wary that they're not developing osteoarthritis. Initially, they'll present with groin pain, which is intermittent, but it then tends to become constant. And it tends initially to be worse on flexion activities or after prolonged sitting, such as being on a car journey, flight, or a dinner. Usually they'll present with a feeling of catching or instability, which is almost diagnostic of a labral tear. When you examine them, essentially what you're looking for is signs of irritability of the hip when you put them into that impingement position. So this diagram shows a positive impingement test, and that will produce groin pain. Another useful test to do is to ask them to lift their leg up straight, and against resistance, that will also bring on groin pain. It is sometimes the case that we see misdiagnosis, and commonly that would be a misdiagnosis of an adductor strain, pubalgia, trochanteric bursitis if the pain is lateral, and potentially a spinal cause as well. What we would say is that a groin strain should get better within 3 months. If it doesn't, then you need to suspect that it's the joint, bearing in mind that patients that get groin strains are usually sporty, and often patients that are sporty will have femoroacetabular impingement. Trochanteric bursitis doesn't really affect young adults, so if they're getting pain laterally, it's almost certainly being referred laterally from the hip joint. And some of these patients in the past, although not so much anymore, used to spend quite a lot of time getting treatment elsewhere, which unfortunately wasn't necessarily helping them in the longer term, as the ongoing damage to the joint was allowed to happen. So I might cut back to Tony at that point, I think, and then we can go back to the treatments perhaps as the third talk, if Tony's ready. Is that okay there?
Yeah, that's great.
You ready to go? Yeah. Okay.
Thanks, Tom.
So I'll stop sharing my screen.
And see if I can get it to work this time.
With regards to the questions, do we want to cover those once we've done both? There are a couple on the chat there.
Yeah.
So Rosie did ask a question, which I think Tony's answered about, does this show that we should encourage children to do less as they grow? I'm assuming based on your talk.
Yeah, I think probably you need to tailor their activities. So one of the physios at Southampton Football Club found that a lot of the kids lost their internal rotation between the ages of 11 and 13. And that was thought to be related to what they were doing as part of their football training. So I think that's something the FA is looking quite closely at.
Okay, brilliant.
Yeah, it's intensity.
We'll hand over to you.
Tom, the issue is the intensity of training that seems to be proportional to the degree of changes that we can see. Well, apologies for having a slight technical issue at the beginning there, but thank you, Tom, for your talk. And my remit is really to talk to you a little bit about hip preservation surgery and how we can help people with certain issues there. And hip preservation surgery is basically quite a big bag, and it describes all surgical procedures that are aimed at preserving the health of the hip so that you're trying to prevent or delay the onset of arthritis. And so you're also thereby trying to avoid or delay the need for some sort of joint replacement. And if we think about groin pain, well, this can occur from a variety of defined clinical entities. And so inevitably, it means that people with groin pain can present to a whole variety of clinicians and as their first point of contact. So lots of our colleagues in the specialties you see there will see these people with groin pain, and many of you are on this webinar tonight. And so sports, in sports, groin pain has quite a high incidence really, and it's most commonly seen in sports that require that repetitive twisting and cutting, the rapid acceleration and deceleration. And so we're looking at all sorts of sports like football, rugby, lacrosse, and hockey. And when we're trying to evaluate the groin pain, we can look at a sort of a layered approach where we start with the osteochondral layer of the femur and pelvis and acetabulum, and then move on to the inert layer, which includes the labrum, the capsule, the ligamentum teres, and other ligaments as well. And then onto the contractile layer, which obviously is all the muscles, and then the neuromechanical layer as well. So this helps us evaluate the problems as we go along. Another way of looking at the different types of hip and groin pain is to look at the site of it. So you can start with the adductor related pain, the sort of more conventional groin strain, or the sports hernia or Gilmore's groin, or what's now termed inguinal disruption. I'll come back to that in a minute. But also things that revolve around the psoas, so you can get a snapping hip or pain over the hip flexors there. the bursa, so you can get psoas bursitis. You can get problems around the pubis, so osteitis pubis or athletic pubalgia, stress fractures of the femur or the pubic rami, and then spinal-related causes of groin pain as well. But of course, hip-related groin pain is also very important, and we've already had Tom's great talk on FAI and where we can get things like labral tears happening as well, but there's other things that can go on inside the hip as well that can give you groin pain. If we move around the side, then you can have a snapping hip on the side from the iliotibial band, and this is what teenage girls often come in saying that they're dislocating their hip, and they can show you this sort of translocating ITB over the greater trochanter. But you can also have abductor insufficiency, so things like gluteal tears and peritrochanteric pain from trochanteric bursitis or calcific tendonitis. If we move around to the back, then you're getting buttock pain, but sometimes even these problems around the back can present as groin pain. So conditions like ischiofemoral impingement or even hamstring tendinopathies or tears. So, there's quite a lot that goes into groin pain, and this can be a very significant pain and disability, and it can often occur in sports, and it has led to a whole variety of terms being used. And on the screen there you've just got some of these terms, but I'm sure a lot of you will have used other terms and would have seen literature about lots of other ways of describing the groin pain as well. And so what has been very important is to try and get a terminology consensus, because otherwise we're all talking about the same thing but using a different term to describe it. And so in 2012, the British British Hernia Society held a consensus meeting, and they decided to change the term of sports groin and use the term inguinal disruption. And so that's really the preferred nomenclature now. And they published that in 2014 in the British Journal of Sports Med. And you can make the diagnosis of inguinal disruption if any of the following three things can be detectable. And so you can either have pinpoint tenderness over the pubic tubercle, palpable tenderness over the deep inguinal ring, and pain or dilation of the external ring with no obvious hernia evidence. And so that's quite important, because obviously if there is a hernia, then that's something different. You can have pain over the origin of the adductor longus, and also this dull diffuse pain in the groin, often radiating to the perineum and the inner thigh or across the midline. However, there are some people who don't believe that a disruption exists, and so you shouldn't be using that term. And Ulrika Muschewek, who is quite a famous surgeon, I'm sure many of you will have heard of her, she says that in thousands of her surgeries, she's seen no evidence of disruption or injury to the conjoint tendon. And there's no hematoma, no scar, no hernia, but there's always a shiny surface. So her preferred term is a sportsman's groin. And she states that there's a weakness of the posterior wall of the inguinal canal, which causes that localized bulging and compression of the afferent nerve. And so they get a neuropraxia, which causes that burning or dull pain. So as you can see, there is a little bit of contention as to what the proper term should be. But then in 2014, there was also another consensus statement that was published on groin pain. And here they used a taxonomy that was based on history and physical examination. And they split it into three major headings. So the first heading is 4 very sort of defined clinical entities for groin pain. And I'll come on to those in a second. The second is hip-related groin pain, and we've already heard some causes of that, and then other types of causes of groin pain as well. And we'll come on to that in a second. So of those 4 sort of defined clinical entities, the first one is adductor-related groin pain, and you can see from the diagram there, the sort of area geographically that it relates to, and it's really tenderness over the adductor tendons more proximally. And you can test for it with having resisted adduction testing. There's then an iliopsoas related groin pain. So you get tenderness over the iliopsoas, and it's more likely to have that sort of pain if there's any pain on resisted hip flexion or pain on stretching the hip flexors. There's also then the inguinal related groin pain, and obviously this is the one that is a bit more contentious, and people are still discussing what term you should really use, despite various consensus statements. And then there's the pubic related groin pain as well, which is localized tenderness over the pubic symphysis and the immediately adjacent bone. And so in terms of assessing these, the pubic clock is quite a useful structure to use. And so you can palpate all the way around the pubic tubercle there. And one thing to draw your attention to is that pubic aponeurosis between the adductor longus and the rectus abdominis. And in fact, there's been quite a bit of work done on this by Childers and his group, where they've actually determined that the pyramidalis is a very important contribution to this. And so they have coined the term of the pyramidalis anterior pubic ligament adductor longus complex, or plaque. And they describe that as being the main issue in sort of pathology in that area. And so with pubic related and adductor related groin pain, is this important? Well, there was a study that looked at 382 consecutive athletic groin pain patients, and they found that the most common was an injury to the pubic aponeurosis, with 62% of their patients. There was also, next to that was the hip injuries, which there was about 21%, but then the adductors had about 15% of those patients presenting as well. And so they found that the adductor squeeze test was very sensitive, but not necessarily specific for the pubic aponeurosis and adductor pathology. Now, examination of the inguinal related groin pain, you do need to do a thorough examination of the hip and groin and need to inspect for any obvious hernias, and also palpate around the structures that were designated by the pubic clock, but around the pubic tubercle, conjoined tendon, and those sort of areas. And you're examining them in the upright position. This particular part of the investigation I don't often do, because I don't think patients really like to have their scrotum invaginated, and so it's something that we often avoid having to do. And obviously, you're trying to exclude a hernia. But probably the best way to test for it is really to do a resisted sit-up. And so when they're sitting up and you're pressing down on the rectus abdominis insertion, then that usually triggers the pain. And if you're trying to image for this, you can use ultrasound. MRI is often not that helpful, but other than to exclude other things. And again, plain radiographs is really just for exclusion. And again, bone scan isn't really that helpful. But as I said, it's really a question of diagnosing inguinal disruption on the basis of having 3 out of the 5 clinical signs. And this has been, as I say, published in the British Journal of Sports Med in 2014. And there's a very good current concepts article by Childers as well, by Ernest Childers in Hip International. If you want to read more about that, then I would commend you to go and look at that article. Now, we also talked about iliopsoas related groin pain, and iliopsoas tendon is located lateral to the iliopectineal eminence when the hip is in full flexion. And as you can see that on the picture on the left, and then when you go into extension, it then flips back medially. And it's really that sort of flicking back over the eminence that can cause that clunk or snap that can be audible and palpable. And the psoas muscle is a composite muscle formed by the psoas itself and iliacus, and it passes downwards and medially behind the inguinal ligament and right over the front of the hip joint. And so it can snap over the femoral head or the iliopectineal eminence. And so it can be associated with very large cam deformities, giving you that snap, and it can be associated with labral tears. Snapping can occur in about 10% of the population without pain, and this is normal. And so it's only really the symptomatic internal snapping hip syndrome that we worry about, and it presents with groin pain associated with the snapping phenomenon. Other things you can get in that area are bursitis and muscle tears, and we often talk about the musculotendinous unit of the psoas, and more than half the cases that we see with the sort of snapping are associated with intra-articular pathology like labral tears. And so if you are getting to the point where you're thinking about treating the sort of snapping surgically, then you do need to look at the central compartment with hip arthroscopy as well. And this is the cross-sectional analysis of that musculotendinous unit, and you can see that, you know, over the front of the hip joint, you've got 40% tendon and 60% muscle, and a bit lower down, it's about 50-50, and then down further still towards the lesser trochanter, then you've got a lot more tendon and less muscle. And so the tendon tightens as it becomes inflamed, and that's partly the reason why it then starts to snap, as well as running over those bony prominences. And there can be predisposing factors like femoral anteversion, trauma, or even, you know, we can see this happening with joint replacements. So total hips or hip resurfacings can also give you this sort of snapping phenomenon and pain. And so in terms of examination, you've got the patient lying down, you take a flexed hip into extension, and as you do that, you can reproduce that clunk, and you can even feel it. And sometimes you can stop the snapping by pressing down over the psoas tendon. Now, the other category to talk about is hip-related groin pain, and Tom's already mentioned some of this, so I'll skip through it quickly. But the C-sign distribution is something that often they'll come in and point to the groin, as you can see in this picture. And we've already talked about the characteristic symptoms, so I won't dwell on those. But, you know, looking at gait is quite important, so the difference between an antalgic and Trendelenburg gait. But also very important is to assess the range of motion in the hip. And you can have tables like these that give you the normal range of motion, but you need to also understand why some of those range of motions can be affected by other conditions. And so rotational abnormalities can affect your range of motion. You can see in A, you've got a normal femoral version, and so you can get a normal range of motion. But when you've got excessive femoral anteversion, you can see that you have reduced external rotation. And similarly, when you've got femoral retroversion, you've got very much reduced internal rotation. So these things will play a part. So you can see girl on the left has normal internal rotation, but the girl on the right can't internally rotate her hip because she's got femoral retrotorsion. And so it is important to assess the rotational profile, and we can do this clinically, or we can do this radiologically with a CT scan. And also don't forget tibial rotation. As you can see in this picture, the knees are pointing forwards, but you'll see that the feet are externally rotated, and you'll see the right foot is externally rotated a very long way. And that, of course, has an impact on the hip, because this lady won't walk like that. She'll walk with her feet pointing forwards, which means that the knees roll in, as do the hips. And so that can then cause a functional impingement in the hip as well. And, you know, and the trick there is that the plain radiographs will look quite normal and you won't see a cam lesion, but you get this functional impingement when they're walking. You can see on this case, we've already corrected the left side, but the right leg you'll see is slightly internally rotated at the knee, but even with that, the foot's still pointing out. Now, Tom's already covered the impingement test and McCarthy's hip extension tests. And these are all things that can help us determine whether there is some hip pathology. And probably, you know, the important thing is the McCarthy's triad of signs. So if you've got a positive impingement sign, a positive McCarthy's extension sign, and pain on resisted straight leg raise, the so-called Stinchfield test, then this has a very high predictive value for a labral tear. And sort of Patrick's test, the Faber test, that can also herald hip joint pathology, but equally, it can also stress the sacroiliac joint, so it can be, it can be positive if you do have some sacroiliac pathology. The apprehension test is quite useful. If you do a lateral rotation of the extended hip and you do that rapidly, you can see whether they've got sort of hypolaxity, or if you get apprehension, then that, you know, often happens with groin pain, and it can tell you that they might have a labral tear, or perhaps a bit of hip instability, or even a little bit of posterior inferior impingement. So none of these tests are necessarily very specific, but they do give you an impression of what's going on, and it's carrying out all the different tests that can then tell you exactly what's going on. This is an interesting article from John Khakha, where he looked at all his patients that presented with what he then discovered to be anterior hip impingement, and where they pointed to when they had pain. And you can see 88% of them presented with groin pain, but you'll see there's a whole spread of areas around the body that are, where they felt the pain, even though it was then proven to be anterior hip impingement. We've already talked about femoroacetabular impingement from Tom. This was going to introduce Tom, so apologies for getting that not quite right at the time. So I think, Tom, shall I stop here and then you can come back in and do your second talk?
Yeah. Okay, so, well, that was a very comprehensive view of pain around the hip joint from Tony there. I think it's really difficult to make these diagnoses sometimes. MRI scans we use a lot, however, they'll often not necessarily give you the answer. I think often we use steroid injections into the hip joint or to other areas in order to try and determine whether the pain is indeed coming from the hip joint. And that's really useful technique. So we'll go back to management of FAI now. So hopefully that's all come up on your screens there. Essentially, as with any musculoskeletal condition, we want to put patients through a conservative treatment process initially, and then only move on to surgical treatment if needed. And the case with a mild deformity, perhaps with relatively mild symptoms, may well be able to away with conservative treatment. So what that means potentially is activity modification, steroid injections and anti-inflammatories, potentially when their symptoms flare up. The problem is that the majority of patients we see in clinic have already tried to modify their activities, or they're not prepared to modify them because it's their exercise and their day-to-day lifestyle that is causing their symptoms. And also their symptoms tend to be constant by the time they get to see us. So they'll have had that intermittent phase where it's been every now and then with certain activities for a number of months, maybe even years. And now once they get to attend an outpatient appointment, then actually their symptoms are there pretty much all the time, and they're quite disabling. And in fact, a study has shown that patients with FAI that make it through to a clinical outpatient appointment usually have similar severity symptoms to those patients with osteoarthritis that are undergoing hip replacement surgery. So when we get them through for surgery, obviously we've made the diagnosis, we've excluded all of the other possible causes of pain around the hip that Tony alluded to. What we want to do is repair the consequences of the impingement and also be able to address the underlying deformities in order to stop the impingement coming back in the future and causing all the damage yet again. So when we think about labral tears, it's important to consider what the labrum actually does. And to be honest, over the years, this has been a slightly controversial topic. The function of the labrum wasn't entirely clear. We now consider that it works as a suction seal around the hip joint itself to maintain synovial fluid within the joint space, and that's how articular cartilage gets its nutrition. It doesn't have a blood supply, so that seal is thought to be very important. It acts as a mechanical bumper between the bony rim of the acetabulum and the femoral neck, although I suspect on most movement this isn't particularly important. It's very well innervated, and there's certainly proprioceptive function as well. The labrum's well innervated and well vascularized, which means it's got a good potential to heal. And when it's torn, its function's compromised, but also pain will occur. So in terms of how we deal with those tears, If we were to trim them away, such as you would do perhaps with a degenerate meniscal tear in the knee, then that should relieve the pain, but it may compromise the function of the labrum longer term. If you repair the labrum, then you can restore the function, but pain may still potentially be present. And one option, therefore, if the pain is still there, is to actually remove the labrum and try to restore its function by replacing it with a graft. And that's called a labral reconstruction, and something that is becoming more commonplace. So if we consider the vast majority of tears occurring at the chondrolabral junction because of that separation of the two interfaces, when we look at a labral tear at arthroscopy, what we're deciding is this tissue healthy to repair, or is it best to remove it? The vast majority of labral tears now are repairable, and you can see in this case, this is fairly healthy looking tissue. You can see how bruised and inflamed it is there, but this should be very amenable to repair. As the tissue gets a little more degenerate, we used to debride this sort of tear, but nowadays we'd always repair that really to try to restore the function. But you can imagine as the tissue quality gets worse, the likelihood of a successful healing of a repair becomes less. And in this sort of case, really, you're better off debriding the labrum and perhaps, if necessary, considering a labral reconstruction as a secondary procedure. When you repair a labrum, essentially the principles are the same in that you drill behind the labrum. This is on the rim of the acetabulum. You've got the labrum down here. You pass a suture either around or through the labrum and then bring it back on itself, and it's then passed through an anchor which goes into the hole that you've drilled. And you tighten it up and then you work your way along, putting in more anchors to make sure you have a good stable labrum. And usually we'll use, on a typical FAI case, probably between 3 or 4 anchors, but sometimes it may be as little as 2 and sometimes up to 5 or 6. On a labral reconstruction, you'll be looking at many more, probably 8 in total, if you go the whole way around. And once you've let the traction off when the femoral head's back in the joint, you can see how the labrum's being repaired there, and it's sitting nicely around the articular cartilage of the femoral head, therefore restoring that seal. With regards to the chondral surface, so the acetabular cartilage damage, which is where we see most of the injury in FAI cases, essentially what you want to do is create a stable articular surface that can't delaminate further so that you don't get propagation of the damage that's already occurred. So this is a situation that we see quite commonly where you have an acetabular cartilage flap. The concern is that if you left that, then it could still, on movement, ruck up and get peeled off and potentially make that defect a lot worse. And in this situation, you're better off just removing that small piece of cartilage and using a radiofrequency probe, which tends to stick it down nicely so that it won't propagate any further. As things progress, however, you may be faced with one of these bare bone defects. There are various options for how you deal with this. Microfracture, which involves putting holes in it and encouraging bleeding and therefore stem cells to come in from the ileum, is probably the most commonplace technique. It works very well, and you'll get a fibrocartilage covering, which should hopefully stop the femoral head from falling into that hole. But there are alternatives on the market, and some of these are biological and some are more synthetic gels or matrices that you can put into that gap. The challenge is always getting something to stay there that will be resistant to movement of the hip. When we consider the bony impingement, then we want to establish, does the patient have a pincer deformity that needs to be removed? Does the patient have a cam deformity? How extensive and whereabouts on the femoral head-neck junction is it? And we need to consider very carefully that with an arthroscope, you cannot address a shallow acetabulum. So hip arthroscopy doesn't work if the patient has severe hip dysplasia, because what they need is a reorientation of their acetabulum to give them more bony coverage. So with the pincer deformity, essentially you want to remove bone so that you get rid of that pincing effect, and then you can either remove or fix the labrum back. And you do this arthroscopically under a combination of fluoroscopic control. So you can see here the overhanging rim of bone, which you can shave away using a burr. And you can do it as you see here. You'll see the overhang of the pincer lesion, and then you burr it away, and you've got your labrum at the bottom there, which usually you'll then repair back just to stabilize it and effectively create a normal volume to the acetabulum. With regards to the cam deformity, the schematic diagram shows essentially the conversion of a rugby ball shape to a football shape, so that that hip will then flex up without impingement. When you look at it arthroscopically, this is the femoral head-neck junction, top left. You remove the periosteum from it, and you can see this irregular hard bone, which constitutes a cam deformity. You shave it away with a burr, and this is having taken the hip into flexion. You can see that there's a small gap between the edge of the bone and the labrum, which indicates that there's no residual hip impingement. And as the femur comes back into extension, you can see that the weight-bearing articular cartilage of the femoral head has not been affected. We do what's called a dynamic impingement test, which is something that really you can only do satisfactorily arthroscopically rather than with open surgery. So we've got the hip flexed up to 90 degrees here, and we're adducting and abducting, and we can see through this range of movement that the femoral head-neck junction is not impacting on the rim of the acetabulum, and you can see the sutures from the labral repair there. So this is what we're looking for on our imaging as well. So we always check pre and post intraoperative fluoroscopic images. So you can see this case with a large irregular sclerotic cam deformity anteriorly, and then when we've shaved that away, you can see how you get that nice hourglass appearance to the head-neck junction, so that essentially it's symmetrical with the posterior aspect of the neck. So this is all done arthroscopically. We use a supine position technique, 2 incisions for a standard arthroscopic case. Labral reconstructions, you would usually use 3 or 4. We're dealing with the articular cartilage lesion. We're getting rid of the underlying cause, which is the cam deformity, and therefore that should translate to good clinical results. So moving on to results. So hip arthroscopy has been performed for many years, but really the understanding of FAI brought a new application for it, and it really found its place in the armamentarium for hip surgeons. The systematic review from 2010, this is quite a historical paper now, but it's useful to understand the initial experiences with regards to hip arthroscopy and FAI. So if you bear in mind that for any systematic review, the papers included in it are probably going to come from at least 5 to 10 years before the date of publication. So what they found was that the majority of patients had good results. However, there was a high number, so approximately a third of patients, where the results were either unsatisfactory or they were converting to hip replacement for end-stage osteoarthritis. And what they observed was that the best outcomes were in those patients that had minimal degenerative change to start with, that were younger, and that underwent labral repair rather than labral debridement. Based on this kind of evidence, NICE took a view that actually arthroscopic treatment of FAI did have good evidence for symptom relief. However, they made a major caveat that it should only be performed by surgeons with specialist expertise, and that all cases should be entered onto a national register. And that was really the advent of the non-arthroplasty hip register in the UK, which remains the best non-arthroplasty hip register worldwide. Locally, in Berkshire West, funding was approved, which was not the case in many areas in the UK, but there were certain caveats for the selection of patients. So they shouldn't have arthritis, they shouldn't have dysplasia, they should have obviously failed conservative treatment, including specialist physiotherapy. And they made a first of stipulating a list of surgeons who were commissioned to perform the procedure within the Thames Valley, and those surgeons had to be performing 75 cases per year. However, despite these fairly strict criteria for patient selection, it was noted that the demand for hip arthroscopy was increasing, and obviously within the NHS that can present a significant funding issue. So the National Institute for Health Research funded 2 randomized controlled trials. We were involved with one with collaboration with the University of Oxford called the FATE trial. And essentially these studies were randomizing patients with FAI to undergo specialist physiotherapy for 6 months or to undergo hip arthroscopy. And both studies were published last year. Our study was published in British Medical Journal, and the Fashion, which was the other study, in the Lancet. And both studies, interestingly, showed the same result, in that patients having specialist physiotherapy and hip arthroscopy both benefited from both treatments, but the benefit was greater and significantly so in those undergoing hip arthroscopy. And that matches with our clinical experience, in that many patients will get better with targeted physio to look at their core stability, look at how they're moving with certain activities or sports, but often because of the underlying mechanical problem within their joint that obviously can't be addressed directly with physio, while they may transiently improve, they will get worse again with time. Now, there can be failures with hip arthroscopy, and that's something that's well recognised. As we alluded to earlier, patients with severe degenerative change at the point of their hip arthroscopy are unlikely to get better, and those patients should not undergo hip arthroscopy. But some patients can develop scarring within the joint. So this image on top right here shows capsular labral adhesions, where essentially where the healing joint capsule is, where we come in anteriorly, you can get small bands of scar tissue that can stick onto the labrum. And normally there's a space here that allows movement between the capsule and the labrum without any direct contact or traction on the labrum. But in the context of scar tissue, when you move the hip around, this can pull on the labrum, and it can be painful, and it can make it inflamed, as you see in this picture at the bottom right. So that's probably the most common cause for further intervention after hip arthroscopy. Occasionally the labrum doesn't heal, or it re-tears. That's rare in my experience in isolation, and is almost always related to adhesions. Progressive degenerative change can occur. I think sometimes from a biological point of view, the articular hyaline cartilage just gets to a tipping point of no return, where the chondrocytes, which are few and far between within it at the best of times, just can't keep up with the damage that has already occurred. And in that case, the patient will develop progressive degenerative change. And then some patients have unexplained pain, and these are always clearly a difficult problem. You need to try and work out, is the pain coming from elsewhere? Is there any psychological overlay? And also some patients have unexplained pain. They don't have pain anywhere else. You do a hip replacement and they seem to get better, despite not having arthritis that you can see in the hip. So for a successful outcome, patient selection, as with any operation, is absolutely key. You need to avoid cases with degenerative change, and pattern recognition here is extremely important. Don't rely on imaging reports from radiologists. You need to understand the shape of their hip and the hip morphology and what you can and can't achieve with arthroscopic surgery. And some deformities are just too severe to be able to be corrected. You need to manage the patient expectations and consider the patient profile in front of you. So are they going to be a patient that responds well to treatment? Are they prepared to go through the rehab? And is it realistic, their goals, compared to what can really be achieved in their case? You need to do effective surgery, and I think we're at the point now where hip arthroscopy is generally performed by specialists, but there are occasional episodes where that may not be the case, but few and far between, I'm pleased to say, in the UK. And then they need to undergo appropriate rehabilitation, and that's where close working with your physios and collaboration and understanding of the goals is really important. So generally speaking, we allow the patients to fully weight bear. We focus early on restoration of range of movement, and that's to try to reduce the problems associated with any adhesion development. A static bike can be very good early on for patients just to get things moving again. They can usually increase their impact activity from about 6 weeks on, but you have to be very careful to guard them against doing too much strengthening, particularly repetitive hip flexion, because that can irritate the psoas tendon and be really quite debilitating in the first few months for them. Running's normally about 3 months, and obviously once everyone's happy with their muscle control and strength, then potentially they can get back into sports, and in general that would mean contact sports probably at about the 6-month mark. So for most patients having surgery, you're looking at a season out of their game. So in summary, groin pain is very common in young adults, and you need to consider femoroacetabular impingement as it's probably the most common cause. Most young adults with pain around the hip usually have the hip joint as the source. So if you're thinking of other diagnoses, just be careful that you're not missing an FAI case. And don't rely on radiologist reports of x-rays or imaging, because they don't usually understand all the patterns that are important for diagnosis. Hip arthroscopy is effective, and we definitely recommend it. It's effective when conservative management fails, but it needs to be performed by specialists with good case expertise and experience. Thank you. I've just put up our details there for our website, the Reading Orthopaedic Centre, and I'm sure Rags will upload this later on. Thank you very much.
Thanks, Tom. That was brilliant. Tony, do you want to go through some of the questions and while I upload my talk as well?
Yep. I've still got the second talk to give as well, Rags. But yeah.
Okay, brilliant. So why don't you give your talk, then we'll come back to the questions, then, shall we?
Okay.
Is that better?
Yeah. Okay. So thanks, Tom, for that. So we've talked about the management of FAI arthroscopically, and we've talked about the labrum quite a bit, and how labral repair is a very effective treatment that leads to greater improvement in pain and function and return to activity. But the success of labral repair really sort of depends on addressing an underlying anatomical condition, good surgical technique, as you've heard from Tom, and a very well-motivated patient that goes through a phased rehabilitation program. But there are times when the labral damage is so severe, or if the labrum is either too big or too small, where repair can be sort of less effective. And so there's also times when a previous labral repair may fail, as you've heard, if they get adhesions or some other problems. And so a labral reconstruction can be quite effective. And what a lot of people these days use is an allograft labral reconstruction. And my own sort of experience with this, I've been doing it for about 5 years now. We tended to use autograft initially, but it wasn't quite as good, and then moved on to allograft, which is a slightly easier material to handle, and it can give you slightly better results. So just as a couple of illustrative examples, you can see this is a 46-year-old female. She's had a previous repair, and you'll notice that you can see the psoas tendon right here. You're right by the edge of the anterior acetabulum, right down by the psoas notch, and you can see that the labrum's really very battered. The other thing you can see here is the ligamentum teres that is also a little bit battered. And so we went on to excise that labrum because it wasn't repairable, and we started to put an anchor in here. The other thing we had to do with her, because she had instability from that ligamentum teres problem, is we went on to do a ligamentum teres reconstruction at the same time as the labral reconstruction. And so we did the ligamentum teres reconstruction, and here a picture on the left, you can see the labral graft going in, and then we're attaching it to the rim of the acetabulum here, and you go all the way around. When we then let off the traction, you can see the picture on the left here is the anastomosis between the allograft here on the left, and then what's left of the native labrum on the right. And what you can see is that it abuts the articular surface of the femoral head, so that you're restoring that fluid seal that's really important for a proper functioning hip. If you go a bit further more medially, you can then see that it's got a bit of inflammation down there, and so you might then want to do a bit of a synovectomy down in that area. This is another case where 53-year-old female, and you can see this really aggressive adhesion formation in the anterior part of the hip. So this is the femoral head here. This should be the edge of the acetabulum here, but you can just see a dense sheet of adhesions that's tethering everything down, and so it's not surprising that this person's got so much pain. So again, we just go around, you can see again the psoas tendon here, so you can see how close to the edge of the anterior acetabulum it is. You can also see that when we've taken the labrum down, you can see a very sort of odd shape to the anterior edge of the acetabulum. So there was a hidden pincer behind the labrum, very irregular margin that was contributing to her discomfort. And so obviously we address that, and then we bring in the acetabular, the labral graft, and we secure it all the way around the rim with consecutive sutures. And again, you can see you've got good apposition of the graft up against the edge of the acetabulum, and then good restoration of the fluid seal at the end. So the success of labral reconstruction, again, depends on addressing underlying anatomical problems. It relies on having an intact ligamentum teres. So if there isn't one, you might want to consider reconstructing it. If you don't want to reconstruct it, you shouldn't reconstruct the labrum either, because they're going to have instability and it's then going to fail. Surgical technique's important, a motivated patient's important, and the phased rehabilitation program is even more important, because that really is the thing that's going to give you a good result. Patients who go through reconstruction, they say they feel better than they did with the repair, and they quite often manage to reach their rehab targets at a much earlier stage than the repair group. And some of them say they've got back to normal without any restrictions. So some of the questions we ask ourselves are really, should we reconstruct more often? Should we be using autograft or allograft? Do we need to keep allograft on the shelf so that we can fall back on doing a reconstruction if necessary? And should we be thinking twice before repairing a labrum? Because remember with the ACL, where ACL repairs back in the days gone that didn't really do very well, and so they were reconstructing at the first procedure. And should we be doing that as well with the labrum? We've already heard from Tom that, is there a role for stem cells? Is there a role for a composite chondrolabral graft, so that you're repairing all of these things all at the same time? So I think it's fair to say that the indications for labral reconstruction are growing. If we look at our colleagues over in the US, they seem to be doing more reconstructions now than repairs. In the UK, we're slightly behind on that, but I think it's probably going to go that way a bit more. Some other things we wanted to talk about, the internal snapping hip syndrome. We sort of mentioned this on the earlier talk, and this is what we can see when we look inside the hip. You can see this area of intense synovitis over the psoas tendon. As we take that synovial layer away, you can see the psoas tendon behind it. And you know, in some patients, there's a direct communication between the psoas tendon and the hip joint, so it's not covered by synovium. And so that's why quite often the psoas tendon can be so irritable, so close to the joint. This is a video of the psoas tendon being probed, and you can see the labrum there at the bottom left, and the hook's just probing the psoas tendon. And when it comes to management, you know, again, we can see that it was a tight labrum, was very inflamed initially. We did a little bit of radiofrequency ablation to just see if we could get it a bit more comfortable, but it was still really tight. And so we then just do a little release with the radiofrequency probe like this. And then we can go on to do our labral repair and stabilize things in that respect. So we can do the psoas release at several levels. We can do it at the level of the acetabular rim, a bit higher up, or we can do it a bit lower down in what's described as the peripheral compartment when the hip's not on traction, or we can even do it at the lesser trochanter. I mentioned in the previous talk that we can see psoas problems with joint replacements, and this is a hip resurfacing where you can see quite a prominent edge to the acetabular component, and so that was irritating the psoas. Here you can actually see the psoas tendon running over the femoral resurfacing component, so it's almost like it's running over a mirror, but you can see all these areas of inflammation around it. And again, here, this little video, you can see there's the resurfacing, there's the psoas tendon. And if they're very symptomatic, you might need to consider either a revision of your resurfacing, or, you know, you can do a release of the psoas, and often that's enough to get them symptom-free. The extra-articular release at the level of the lesser trochanter was probably how things got done first. And, you know, this is a sort of picture courtesy of Dr. Tom Bird from Nashville, who used to do a lot of these. But one of the problems was that you could actually get a lot of heterotopic ossification in that area, and so it was a bit of a problem. And here you can see that, you know, one such example of that. But what about other causes of snapping? Well, we can look at the snapping that happens around the lateral aspect of the hip, and in the peritrochanteric space, which is the space between the greater trochanter and the ITB, and it's very analogous to the subacromial space in the shoulder. And so that's the so-called coxa saltans externa, so the external snapping hip. Other things that go on in that area are things like gluteal tendinopathies and tears, the calcific tendinopathies, and trochanteric bursitis. So when examining for this, it's important to identify the site of the pain and look for muscle wasting, and also define the area that's actually very tender. Is it anteriorly over the TFL? Is it one of the different facets of the greater trochanter? And is there tenderness over the ITB in the proximal third, middle third, distal third, or the whole length of the ITB? And again, we want to look at the gait and test for weakness. So the coxa saltans is where you get this snapping over the greater trochanter. The iliotibial band is an interesting structure. It's a thickening of the lateral part of the fascia lata, and it's thickest just below the greater trochanter, receives the insertion of the tensor fascia lata anteriorly and the gluteus maximus posteriorly. And it's been of interest to anatomists for hundreds of years. And Kaplan in the 1950s described how it was a unique structure, and it's only found in humans. So that's what really separates us from the animals. It plays a very important role in stance and monopodal balance, and acts as a flexor, abductor, and medial rotator of the hip. And so it's been described as the pelvic deltoid, so it allows swinging of the knee with the hip. And so it's important in the stability of the knee as well as stability of the hip. And Ober's test is one way of testing for it, in the lateral position with the hip abducted and extended. And if you flex the knee, then it's usually due to tight abductors. if you can't adduct the thigh, whereas with the knee extended, it's actually because of the ITB itself. And so you can measure the distance from the couch, as you can see in this picture, as a sort of an indication of how tight the ITB is. And this is an example of one of our patients who can snap the ITB over the trochanter. And so we get a handful of patients like this every year who come in saying they're dislocating their hip, but what they're doing is snapping the ITB over the greater trochanter. And this is what it looks like when we're looking at arthroscopically. So you can see the greater trochanter there. And so this is a right hip, and the foot's going into the screen and the head's coming out of the screen towards you. And you can see that large flat sort of band as it goes past the greater trochanter. And so how we manage this arthroscopically is slightly different to doing an arthroscopy of the hip joint itself. So we use slightly different portals on the side of the leg. And this is the sort of view that we can see. So you can see the iliotibial band. We could peer through it there through the trochanteric bursa. This is the bursa that you're looking at here now. And you can see the trochanter just coming into view there. And so again, you can see the glute max tendon just into the distance there with a greater trochanter. And this is a right hip again. You can see the needle coming in for your second portal here. So there's your needle, glute max tendon, greater trochanter. And so what we do here is to debride the bursa. We expose the longitudinal fibers of the ITB, and then we can actually do a dynamic test of tightness of the ITB by adducting the leg and rotating it to see how it flicks over the trochanter. And so here we can see the iliotibial band coming close to the trochanter. And of course, this is a patient who's anesthetized, so you can't get them to do that maneuver that you saw on the video earlier, but you can see how tight that gets onto the trochanter. So you can imagine if they were awake, they could demonstrate that flicking over. And in fact, that's what this particular patient could do. So we can do a release simply by just doing a transverse release there, and then we can repeat that dynamic assessment to check for ongoing tightness. And if necessary, we can then go on to divide this gluteus maximus tendon a little bit further down. So we tend to do the division above the glute max tendon so that we can preserve the function of the glute max tendon, but release the ITB more proximal to it. And from a previous series of ours, we could show a significant improvement in non-arthritic hip score by simply doing an ITB release. The other issue around that sort of area is rotator cuff tears of the hip, and these have been described for many years now. Tim Bunker was the first one who coined the term of rotator cuff tear of the hip. And for a long time, the anatomy of the gluteal tendons around the trochanter wasn't really very well understood. And it was very nicely demonstrated in this paper, and how each of the facets have distinct insertions from the different portions of the glutei or the bursa. And so it's important to understand those when you're examining the patient and also when you're looking at some of the imaging, so you can really understand what's happening in that sort of area. In terms of assessing it, we can get MRIs, and you can see on this MRI here, a tear of the gluteus medius showing just there. And again, we can see a tear there. This is a tear on the axial. And so you can get, an impression of these tears from MRI or from ultrasound. The other thing that an ultrasound shows better than MRI probably is calcific tendinopathy. And this is one such example. The MRI is not quite so good at showing that. In terms of managing it, this is what it looks like when you look inside. You can see a big gluteal tear like this. And in terms of repairing it, there's some very good papers that show the specific technique. One of the problems we face is that sometimes it's not the gluteus medius that's torn, it's the minimus deep to it. And the only way to get to it is to actually take off the medius first, go in, repair the minimus, and then repair the medius over the top of it. So it can be quite challenging sometimes to affect a good gluteal repair because of that. And we tend to use these big anchors that have an open architecture so that you can get really good healing into the bone from that. So these are the so-called helicoil anchors. And this is some photos from one of my cases doing such a repair. And here you can see an example of calcific tendinopathy. You can see on fluoroscopy this large calcific deposit just by the trochanter. And this is what it looks like when you look inside. So we've got a needle just holding the calcific deposit down before we can then excise it. And you can then take it away. Now, lastly, the posterior hip, the so-called subgluteal space, the sort of things we're looking at there are things like sciatic nerve compression or ischiofemoral impingement. And ischiofemoral impingement refers to the space between the ischial tuberosity there and the lesser trochanter. And as you can see, sciatic nerve runs very close to that. And so if you've got a very narrow space there, you can compromise sciatic function as well. But the other thing that happens around that area is, of course, the origin of the hamstring tendons. And so you can get a problem with that as well. And there are certain other sort of neurogenic causes of pain in that area. And so it's important to understand the anatomy and which bit you're trying to palpate for which condition. And so, it's really important to do a dynamic assessment of this. And I'm sure you all know the piriformis stretch test, which stresses that. The ischiofemoral impingement, you put them prone and then you take the leg into extension, adduction and external rotation. So you're squeezing that ischiofemoral space and provoking pain. The other thing you can do is get them to walk, and with a long stride, so you get them to do a very long stride. And if they get pain when you do heel strike, then that tends to point to a hamstring problem. Whereas if they get pain with extension, that's usually because you've shortened that ischiofemoral space. And so it's an impingement process there. And there's a whole series of differential diagnoses in that sort of gluteal space that we can share that list with you. So in terms of ischiofemoral impingement, this is an MRI scan, and you can see here that there's the ischial tuberosity. This space is very narrow at 12 millimeters, whereas that's a more normal space of 20 millimeters. And so if we did want to do something arthroscopically, we could go in and resect the lesser trochanter to open up that space for it. If you get a hamstring avulsion, as we can see here, you can go in arthroscopically and repair those. In my practice, they don't tend to come in quickly enough, because you can only really affect a good arthroscopic repair if you catch them in the first few weeks. If they're past 6 weeks from the injury, you can't really do that very well arthroscopically, and you're better off doing it through a mini open. Of course, after any operation that we've described today, correct rehabilitation is very important. And this is really where we rely on physiotherapists and hydrotherapists to get the best possible outcome from the surgery. And the use of ice packs or game ready or physiolab devices, and also appropriate analgesia, is all important. If you want to look at more information about this, there's 2 books I'd recommend. One is the Hip Joint Restoration book, which was written by a lot of very eminent surgeons from ISHA, the Hip Preservation Society. And then the one that's just been released this month, Hip Preservation Surgery, written by ESCA, so another society, the European Society, that again have produced a very good book. The other thing is that we have an annual scientific meeting for the ISHA, the Hip Preservation Society. This year it's going to be a virtual meeting because of the pandemic, but next year it's going to be a face-to-face meeting in Ottawa in Canada. So do come along if you want to learn more about these topics. There's also a website where there's quite a lot of information about these topics as well. So do visit that as well. Thank you very much.
Thanks, Tony. That was a really comprehensive overview, and thanks to Tom as well. I think you covered a lot of ground there. Tom, I think there are a couple of questions that you may want to pose to Tony while I upload my talk. Is that okay? Yeah,
I mean, I've actually answered them on the question answer session. There were questions about how a patient with a snapping ITB goes on to develop tightness there. Yeah, we've answered that on the chat. But essentially, it starts off being a hypermobility issue, usually in a female patient with high offset hips. And I suspect they go on to develop inflammation over the trochanteric bursa, which then leads to pain and tightness secondarily. Questions about acetabular retroversion and whether you manage that with arthroscopy or periacetabular osteotomy. So that largely depends on the volume of the acetabulum, and this goes back to the point about understanding the hip shapes and what the best option is for that patient, and appreciating the need for different tools for each patient. And that was about it. Injections as well, using those as diagnostic tests is really important.
So great. I'm just going to summarize and finish up. So like I said, we're really privileged and lucky to have Tony and Tom as part of the team. This is just a bigger team that includes Tom and Tony, orthopedic specialists. So as you would have heard, both Tom and Tony have got lots of experience with hip preservation, and certainly are leading on the forefront of contemporary hip arthroscopy techniques. And they're part of our team and consulting out of Harley Street Hospital, as well as their centres in Reading. So if you do want to speak to them, get in touch, please feel free to do so, and thanks to them again. I'm just going to finish up with the ways in which you can contact. So you can apply for your CPD points. I'm going to send out a questionnaire tomorrow, which if you could kindly fill in and email that back to us, we'll forward us a certificate of attendance, as well as 2 CPD points that have been awarded by the Royal College of Surgeons. Our next webinar is going to be in 2 weeks from now. It's going to be actually by, interestingly, by a pain specialist, Stefano Almisani, who's a member of our team. In cases where it is really difficult to manage joint pains, where there's no clear-cut MSK pathology. And so this is a holistic approach to managing patients with musculoskeletal pain. Please follow us on Orthopedic Specialists. On these sites, we'll publish all the patients that we interesting cases that we have been looking after that may be of interest to you, as well as the upcoming talks. There are some Twitter handles on there. Tony and Tom have got their website at Reading Orthopedic Centre, so feel free to please visit their websites, and their secretary's details are just underneath there. Should you wish to have any help with your patients, managing your patients, or discuss anything, as well as visiting us at our Harley Street Specialist Hospital, to either sit in on consults or come and see some surgery in the areas that we manage, please do get in touch. We always welcome people to come and have a look. So I'm gonna end the webinar there. Thank you, Tony. Thank you, Tom. Really appreciate you taking your time out this evening tonight, and all the delegates who have attended. Thanks, everyone.
Thank you for attending.
Thanks, everybody. Have a good evening.